Cool. All right, we can get started. Can y'all hear me okay? Cool. Hi, everyone. Welcome. This is the third day of our Voices for Change conference here at CPEN, and you're in the workshop of Envisioning the Future of Public Health in California. So I'm Wei Yu, and I'm here with my colleague Joel. We'll be your facilitators and tech assistants for the workshop today from CPEN, and we have amazing panel for you today to talk about the workshop. So before we start the workshop, I wanted to just provide you with a couple of reminders for you as the audience. First of all, you'll be in listen only mode, but please feel free to interact with the panelists, with the CPEN tech assistants using the chat function. So some of you might be logging in via Whova, some of you might be logging in from Zoom, but either way, please use the chat functions to interact with us if you have any questions or comments for the panel and for us. The recording and the slides will be available after the workshop, after the conference, and they'll be emailed out to all of you. Some reminders, we don't have a formal evaluation for the workshop, but please, if you could take 1 minute to go to the workshop under Whova and rate our sessions, because your feedback will help us improve our future conferences. We do have an office hour today after the workshop, so today is our actually technology. Sorry for the for a text on the slide. Today is on technology. So if you want to check our office hour, please interact with us via Whova at 12:30. And then finally, you could also check out a virtual exhibit hall to connect with our co-sponsors. So yeah, I will now pass it over to Sarah, who will be your moderator for the workshop.
Thanks so much, Wei Yu. And I really want to say thank you to the CPEN team for inviting us here to talk about public health and bring the public health perspective to this awesome conference. I'd also like to thank all the speakers who I'm going to introduce in a second, and thanks to the audience for being here today. We look forward to our conversation with you. I'm Sarah DeGia. I'm the CEO of ChangeLab Solutions, a national organization that works across the nation to advance equitable laws and policies to ensure healthy lives for all. We're an interdisciplinary team of lawyers, planners, analysts, and other professionals that work with community-based organizations, governments, and anchor institutions to help them create thriving, just communities for all. And I'm joined today by Meredith Lee, who is the director of the Health and All Policies team lead for the Office of Health Equity at the California Department of Public Health. Dr. Clayton Chow, who's the agency director and county health officer for Orange County Healthcare Agency, and Solange Gould, who is the co-director with Human Impact Partners, a national organization. And you can read more about their bios in the section on Whovia. But today I just want to welcome everyone for being here today. We're going to talk today about the role of the public healthcare system, and we're going to do more of a fireside chat here today rather than some, entire presentations. But we really want to talk about the role that public health has, both in addressing our public health challenges like COVID, but also in their important role in addressing social and health inequities. Even before the COVID-19 pandemic hit, Black, Indigenous, and people of color were more likely to face health disparities, lack access to health care, and experience unequal access to the systems and environmental supports in their communities, and also from agencies and institutions that are supposed to help. And these disparities were only widening before the pandemic hit. For those of us who've been working on eliminating and reducing disparities through our personal and professional lives, the disproportionate impact that COVID has had on BIPOC communities wasn't surprising, even though it's been extremely heartbreaking. But what COVID has done is really uplifted for everyone the inequities in our systems. I mean, it's really shown to us those who care and those who don't care about these inequities. We're in the midst of facing very challenging times, both to get control of the pandemic and also how we think about the road to recovery and the ways in which we need to eliminate those disparities. And I think to me, that's sort of the light in these dark times, is really thinking about how do we build our systems back better so that we can try to eliminate these inequities and disparities. So I want to open up the conversation to my my panelists today. And first, if you could share a little bit about the role that your organization has played during the COVID response. Who are the types of audiences and communities that you've been working with, and what are the types of resources that you've been able to provide? And I'll go ahead and start with Meredith Lee. Just she's on the first one here on the list.
Thank you so much, Sarah, and thank you all for having us here today. It's a real privilege and honor to be with you. So again, my name is Meredith Lee. I'm with the California Department of Public Health in our Office of Health Equity. And I'll just say just quickly about me is I've been wearing, I think as many of us have during this pandemic, a few different hats. So in addition to my role as the team lead for our health and all policies work at the Department of Public Health, I'm also been co-leading the COVID health equity response from the department for about the last 6-8 months. Time seems to run together these days. I'm not quite sure how long it's been. I was also the acting assistant deputy director for the office up until just recently. And I'm not going to go talk too much about all the different detail in terms of what the State Department of Public Health has been doing in terms of COVID. I think many of you are probably familiar, to at least to some degree, with our role in helping to respond to the pandemic. But did want to highlight just a couple of key areas that I think are particularly relevant to this group. So specifically, I want to talk about the COVID, our health equity metric. And so part of the reopening, so the part of the blueprint for reopening, back in, I believe it was August or maybe September now, we created the COVID health equity metric. And so this looks really at testing positivity rates in our lowest performing census tracts. So using the Healthy Places Index, so looking basically at those who are the least advantaged and saying that we can't reopen counties on the backs of our most disproportionately impacted. If their rates of COVID or testing positivity are higher, then we shouldn't be opening and moving to a less restrictive tier. And I think I'll just say, I think this is, we got a lot of pushback when we first started talking about the health equity metric. Counties were raised in really good fears, like would it just perpetuate blame in terms of, blaming our particularly low income and populations of color for holding back the rest of the county. And what I'll say is I think it's been a real success. And I've actually been hearing a lot from our counties and CBO partners that they're able to lift up and really target investments more into these communities who we already knew were disproportionately impacted, and really thinking about how to recognize that we can't reopen in advance if not we're not moving all together. So I think that's been a pretty big game changer for the department and for the state in terms of this work. And then there's also been a number of supporting tools that have come along with that. So hopefully you have seen and would welcome this group's continued input on, we call our COVID Health Equity Playbook for Locals, or we refer to it just as the playbook. And I know some folks on this call actually helped provide input into that, but the vision is that to be a really living document so that we can be collecting and hearing best practices from local communities, and then sharing those back out across the state so that others can learn from them. And Sarah, I could keep on talking, so maybe I'll just pause there and see if you want me, how much more detail you want me to go into. Maybe I'll turn it over to my colleagues, and then we can always come back if you want to hear more.
Yeah, I think it would be great. So to kind of get the local perspective. So Dr. Chow, if you don't mind sharing a little bit about, what has this been like in Orange County? How has the agency been responding, and what are some of the audiences and communities that you've served?
Thank you so much, and good morning, everyone. Yes, good morning still. It's a privilege to join the panel to talk about this issue, which is dear and near to my heart. All my public health experience prior to this pandemic has always been in the HIV world. And so I assume my position as the Healthcare Agency Director for Orange County in May of 2020, 2 or 3 months into the pandemic, and then assumed the role of the health officer in June. I think when I assumed my role, quickly looking at the data, and we realized that there are pockets or neighborhoods in Orange County that are heavily impacted by the pandemic. And it's not a surprise that those are the neighborhood of the census tract that are part of the lowest SES quartile in Orange County, the socioeconomic background. And you said it right. The one thing about this pandemic that's really a real reckoning for us is that this issue of social and health inequity that existed way before the pandemic, we have to address it. If we don't, the next pandemic, and then I know we're going to have a conversation about the future of public health. If we don't, the next pandemic the history will repeat if we don't do this, right? And so early on in late May, June in Orange County, we worked together with our local partners, the community-based organization, the school district, the community clinics, to really hone into tackling the issue of high positivity rate in the lowest SES quartile, and mainly the Latinx and the Black community. Um, um, by May, we had a map that we show where the infection rate were in Orange County from the beginning. In Orange County, the very first case was actually we had the first case in California in early February, and then carried out all the way to late May. We know that the area that are impacted by social and economic issue, people who living in impacted apartments, people who really don't have the luxury to work from home, telecommute like we do, most of us do, because they have to show up to take care of those essential services, the grocery worker, the the yard worker, the people who do the cleaning on the street and what have you, and they are impacted, right? And the positivity was really high, and so we corralled and created the Latin Health Inequity Initiative, and get all the partners together. And we've been going into the individual neighborhood and get people out tested, send out promoters or a community health worker to a family, educate them about the pandemic, educate them on what to do if they tested positive, and also finding them opportunity like a hotel, or motel, so that they can get quarantined or isolated once they get tested positive, or they've been exposed. And we were able to, within less than 2 months, brought down our positivity rate in some neighborhood an upward of 27, 29% down to 1 digit. But that is a community effort. And we know that there is no way the government, public health department can do this alone. We need to have partnership with community-based organizations, not only organizations that provide health services, but also organizations that provide social services as well, right? This pandemic has shown us that people are disadvantaged, not on the health side, but on the social side, etc. So that's how we approach it. And the same way we're approaching the vaccination now, because we know that we need to take care of people who are most vulnerable and ensure that they are well protected before we move on. So I think I'm going to stop there and continue later.
Yeah, no, it's a great segue too, because I think emphasizing your point about having those partnerships in the community, having partnerships, across different sectors has been something that this pandemic has really shown, and the need for you to be effective in public health, you need to have those partnerships. So I'll turn to Solange, because you have a lot of partnerships with community-based organizations. Can you share a little bit about your organization's response to the pandemic?
Yeah, thank you for having us here, and it's really good to see everyone. So one of the ways that we responded to the pandemic and all of the inequities that the pandemic highlighted was really what we have done, which is continue to provide public health support to California movements and organizers. So for example, we worked with the Warehouse Workers Resource Center, helping them understand, researching the health impacts of Amazon warehouse working conditions during COVID, in order to push back and provide more worker protections. We've been working with Right to the City to put out a national housing justice platform, and also working with affiliates in California on housing justice. There's a platform now called Housing is the Cure that really has public health at the center of it. We worked throughout with to support criminal legal system organizers to decarcerate prisons, jails, and transfers from jails to ICE immigration centers, and divest from policing and invest in health, which is something that we're, as a field, really trying to figure out what that means after, taking it from a slogan to an actual implementation of how to divest from systems of harm and invest in health. We also worked with California local health departments to strengthen their capacity to work with organizers. So a really amazing example is Santa Barbara Health Department. We spent several years fostering strong relationships between them and farm worker organizers. And so those long-term relationships really allowed them to protect farm workers in a more intensive way during COVID. And then just organizing public health practitioners. We ourselves need to be organized. And so we spent a lot of time getting public health practitioners to take state and federal action to advocate for policies to protect communities, and also the social determinants of COVID inequities. So I'll just stop there.
Thank you. That's really great. Because I think out of all of those different responses, there's going to be some lessons, right, that we're all taking away. So I kind of want to shift a little bit to like thinking about lessons learned as we then also talk about like what are the long-term solutions. I wanted to just share a little bit too. So Change Lab as a legal and policy organizations, one of the things that we found was all of a sudden a lot of legal questions started popping up, particularly around public health authority. What is the authority of public health during times of emergency? How do we make sure that that folks are getting the right information? And so we kind of opened up our technical assistance lines, and we received the wide range of different types of legal questions. And it was great to be able to dig in a little bit and help people kind of surf through and really provide some timely response to some of these questions. But we had lots of questions, everything from how undocumented immigrants can access different services that were being passed through different policies. What are the best practices on housing and tenant protections? And again, we received a lot of information about, what can public health officials do during times of emergencies? And then during this time, we also released a report that talked about equitable enforcement in public health, because in order for us to make sure that people are following through the different public health needs and the requirements, if you will, you have to have some level of incentive enforcement. And so we offered a guide to the public health field during this time to help really ask some questions around who's doing your enforcement and how are the systems set up? Are you perpetuating inequities within your disciplinary system? Are you offering different types of options for folks who are, say, low income and who can't afford fines? So that guide is available in the resources section. We have different resources from our different panelists today. But let me pass it back to the panel to see if there are any other kind of insights or responses before we move on to the question about lessons learned.
I think I would add that historically, certain community do not have the level of trust in government entities that would create an effective communications and relationship. Mm-hmm. And I think that lack of a better word, damage, historical damage have been there. And so it would take a lot of effort for government entity to really be mindful of what we do, right? I'll give you an example, even the system on how we register people to get the vaccine. If I'm somebody who undocumented, there's no way in hell I'm gonna, sorry, didn't mean to say that. No way on earth I'm gonna register in the government system to get my vaccine. Because who knows what's gonna happen? And so we really need to be mindful of those most vulnerable. In time of public health need, we have to be mindful on those who we unintentionally will leave behind. And those are the entity, the community, the neighborhood that are most affected. And so I've always say that is that when we do things, how do we outreach the most vulnerable um, community to ensure that they work with them? And so it begged the question of how do we partner with community-based organization to do this, right? Thank God we're under the emergency order. Otherwise, if you want to have a government contract with a community-based organization, that contracting process sometimes take a year for it to get done. How do you work with community-based organization that the contract can't be signed in a year? People can't wait for a year for services. So that speaks to another issue is we have to relook at the way we contract with community-based organizations to do important work that affect the livelihood of the community.
I'm so glad
Sorry,
that you said
I'm
that.
going to stop that before I get a pink slip tomorrow, right?
No, I'm really glad that you said that. And I will invite my colleagues here to chime in because I know that that's something that's been raised a couple times too in other venues.
Well, and Clayton, you stole the words right out of my mouth. And it's literally, it's, you know, there's so many systemic barriers that we have to doing the work that we need to do. I mean, and some of, I think our job is, and speaking from a state and local government perspective, is how do we get out of the way of our community how do we resource and then get out of the way of our community partners to be able to really do the work that they are and sometimes better able to do than we are. And really, I mean, I still think we need to learn, we being larger government need to learn and build skills and build relationships and invest the time and energy to trying to repair some of those harms that we've done. And step one is to acknowledge that we have created harms and that we've perpetuated them and we continue to perpetuate them today. And so I do think we're taking the right steps. Government, and I'll speak simply from state perspective, we're a huge bureaucracy, and things move slowly. And so while we continue to work on ourselves and we also need partnership to continue to be pushed to continue to work on ourselves, you know, I think making sure that we're resourcing the partners who can do the work on the ground. And I did just want to highlight Department of Social Services just issued, I think it's close to $20 million that's going out to CBOs and, you know, small-ish grants to help with our COVID response and doing that community outreach, connecting, you know, those harder to reach or hardly reached populations to the services they need. And I'll just also highlight that, you know, we have the opportunity now with the state received $1.9 billion from the last COVID package from the feds. 1.2 billion of that will be going out to local jurisdictions. And so I also think that's a huge opportunity to think about how do we utilize that money and get it into the hands. Also recognizing that our local health jurisdictions also need the resources to be able to support the back-end infrastructure because we have so chronically underinvested in public health. But how do we also make sure that some of that money is actually going directly into the hands of the community members that we're serving to, you know, for all the other benefits like economics, you know, job growth, everything else, but also, you know, then to actually be able to reach the communities that we need to be reaching.
Yeah, I'll just jump in with a few more thoughts. I really appreciate the honesty of governmental public health at this point. And I think that honesty is really important to rebuild the trust, as Meredith talked about. And, you know, I spent a long time, probably close to 20 years in governmental public health, and I'm now outside in a nonprofit supporting health and social justice. And so one thing I really learned in my time in governmental public health is that when we worked with organizers in an inside-outside strategy, we got a lot more work done to actually change the root causes of health, which are often politically contentious in areas like climate change, housing, economic policy. And so we really need to invest in our long-term relationships in government, and community organizers and community power building organizations need to also invest in our long-term relationships with those allies inside government. It goes both ways. Like, we really need to actually find our people inside government and support them, because we saw a huge exodus of our greatest public health leaders during this time who were targeted, who didn't have support of their own leadership. And so a lot of the ways that our public health leadership survived this time was by working with organizers and using an inside-outside strategy to make sure that they were protected when they got up at that Board of Supervisors meeting to demand strong public health protection. So just being more coordinated and co-conspiratorial inside and outside of government. And that takes years. Those relationships take years to build.
Did you want to chime in, Dr. Chow?
I think I think the issue here is that before the pandemic, ordinary citizen probably didn't know what public health is all about. They probably didn't know who is their county health officer and what exactly is it that public health does, except for sexually transmitted disease like HIV and gonorrhea and what have you, right? That there's more to public health than just communicable disease. And I know we're going to talk about this, is how do we prepare ourselves for the future of public health in California? So I'm going to wait till then. So like you speak up the most important piece, and how do we support ourselves from a community perspective, and really focus on public health, focus on health. Because I know I tell you this last, I guess now going on 9 months being a health officer, no, 8 months being a health officer, I can tell you, I got hate mail, hate email, hate text messages. People show up to the board of supervisors saying erroneous stuff, wrong stuff. Where they get the information, I don't know. And I even get folks who picketed in front of my house, my address and phone number blasted everywhere. So it's really is difficult for physicians who have not been exposed to this sort of ugliness. I'm going to say that. It's very hard to sustain yourself. Thank God for my therapist. Although she's still saying, why on earth did you take this job in the middle of the pandemic, right? I think there's some people who still not realizing that this pandemic, this COVID-19, infected at minimum close to 28 million Americans and have taken close to 500,000 lives. Those are not fake numbers, no pun intended. I'm not quite sure where people get the idea that that doesn't affect them. That's the hardest thing to see, right? Especially today when we have the vaccine, which I say is the beginning of the end of this pandemic, and there's so much hope that people are still fighting with the mask issue, the vaccine issue, and then we still have death. And death here are the senior American who dying. That is the most unfortunate perception. Every day I get reports from how many people who have passed, and it's just painful, even more painful now. Okay, I'm going to get emotional than before the vaccine is available, because it's unfathomable that people still don't believe that this is a pandemic. We're in the middle of the pandemic. Sorry.
No, I want to thank you so much for your passion and your commitment, because what you're saying is right, is that when we're in normal, healthy times, nobody knows public health, right? And that's kind of the way it should be. I mean, it should be in the sense that like you're doing your job and everything is going really well. And it's in a time like this, right, where there's heightened scrutiny, where, you're really the target of, if anything goes wrong, people are sort of looking to lay the blame. And one of the things that I feel like this pandemic has done is it's sort of eroded some of the civility that we have, right? I mean, it's shown us on one hand that we are all deeply connected. We need each other, we miss each other, but it also means that your actions have consequences for my health. And I think that instead of sort of bringing us together in a way, and in many ways, it's sort of deepened some of the divides that we're seeing across the country. So I really appreciate you actually sharing your personal experience and what it is like to be in this position of leadership, because I think people don't understand that what you're facing on a day-to-day level, and that you really see the numbers every day, and they're people to you, right? They're in your community. And I can't help but also think of the importance of the levels of government and the coordination that levels of government are, again, a time like this are really needed, not just in a pandemic, especially in a pandemic, but not just in a pandemic. The coordination of government between local, state, and federal, and how they really play on each other. And when there's rifts between those levels of government, that's going to be felt particularly at the local level. So I'd also love to just kind of hear from the panelists too, what are some of the other things that you're learning or seeing that are both trying to address these issues of mistrust, of civility, of kind of really getting this correct information out to people? And also, how are you working across different levels of government, or like where are you seeing that coordination really positive, and where can we learn from that as we're going forward?
I would ask my other two colleagues to voice in first.
I'll give one example that's just about protecting workers, which I think has become such a big source of inequities in COVID, are low-wage essential workers, that we have no, real public health infrastructure to address. And so it's become really clear that, not only has austerity gutted our public health system, but it has also gutted our Cal OSHA capacity. And at the local level, we have these two bodies that are there to protect worker health, and that don't have the relationships and don't have the capacity, the training, the staff, et cetera. And so you see a lot of local health officers working hard to protect workers, but they have this, regional Cal OSHA office that they could have much stronger relationships with. And this speaks to the power of health and all policies at the local level. So the state CDPH occupational health branch and the state Cal OSHA have during this time been building stronger relationships out of necessity, which has been incredible. And they've passed some incredible emergency standards to protect workers, which are now coming down to the local level. And now it's going to be on the local health departments and the local Cal OSHA branches to work together to really enact those. And then if you want to see, like at the federal level, the Trump administration was pushing through erosions to worker protections that they were trying to get through at the very last minute that would have completely undermined the California state protections. And fortunately, we now have opportunities to push for stronger federal protections that would allow California to go even further. So that's just like one example of protecting workers at many levels of government.
Thanks, Solange. That's a great example. Meredith, did you want to chime in before we kind of shift the conversation to, like, what do we do in the future, right? How do we kind of build towards those kind of long-term solutions? So Meredith, and then we'll pose that.
Yeah.
I'll pose that last question before we open it up to the audience for questions.
Yeah, this is sort of answering your question. It's a little bit tangential, but I think Solange was hitting on it a little bit, that it's not just the up down between Fed, local, or Fed, state, and local, but also laterally within. And so thinking about, and this is wearing my health and all policies hat, but what we've seen, I think both at the state level and then repeated at the local level, and Solange just highlighted this, is that when and where we have relationships with our partner, sister departments, agencies, and we have those established, relationships where we know who to pick up the phone and actually call, it's made a huge difference in the pandemic in terms of our ability to be able to respond and to really address, so many of these issues that are intersectoral. Housing and homelessness is a great, terrible example in that, to think about all the intersection of who all, it needs to be at the table for us to be able to think about how do we really serve this population. And so I think, this is a little bit, I think, going to your next question, but, I think thinking about the future and what can we do differently, I think lifting up models like health and all policies, and call it whatever you want. I'm not wedded to a name, but, this intersectoral partnership and collaboration that really centers health, equity, and sustainability at its core, And how do we really think about, having those relationships at the local level, the regional level, the state level, and the federal level, and then kind of in all the, iterations in between.
So the only thing I would add is that throughout this last 12 months, the most misfortunes are two pieces. First piece is the inconsistency from federal to a state to local. And people really don't understand that public health is local. What's happening in the local jurisdiction speaks to the need of the local public health approaches, right? You saw the inconsistency in messaging from the WHO to the CDC to state to county that create a huge confusions. And the second piece of that is media didn't help at all. Media just goes straight to what is negative and exponentially create is even more confusion for the world. In a state of desperation for this pandemic, I think that has created much less hope for the community. I know when I talk to the media, sometimes I said, negative story is not helping the community at all. You really need to feature bright spot, the ordinary people throughout this whole year. It's not that the government does this. It's not that the CBO is doing this. There are so many ordinary people, local heroes who were doing things for their own neighborhood, for their own community, that nobody featured them. Right? I tell them is that I'm not that interesting. Don't do story on me. Find the heroes in the community and feature that, because those are the story of hopes in the moment of despair for the community. That's one thing that I would point it out.
That's really insightful. I really appreciate you, and I think that as in some of the sessions that I've been able to hear here at the CPEN conference, I have been able to hear some of those bright spots amongst a lot of the very challenging things that have happened. And I know that some of that information has been shared, I think, at the statewide level too, because I think there's a call to action, right? People are ready. They want to dive in. They want to help. The question is kind of how do we plug in, right? What can we do to be helpful? So kind of back to your point about, we're all connected and we're ready to make action. It's been a little hard, right, to kind of get those systems coordinated in a way that we can really help take those bright spots and scale them up at a level that could be much more effective across the state. So I appreciate you raising that. So the question I wanted to ask here, and then we'll go ahead and turn it to the audience. There's a couple questions that have already come in, is what do we do next? How do we think about the long-term solutions to go from here as we start to build towards recovery? I know that we're still in response mode. And in particular, I'd love to hear your thoughts around I think all of you have mentioned we need to address inequities, systems of inequities as we're going forward, because our systems were broken before we got into the pandemic, and this only exacerbated those inequities. And so I really love to hear your thoughts on how do we move forward towards recovery in a way that's going to center BIPOC communities, LGBT communities, immigrant communities, women, all, the folks who are really disproportionately impacted during COVID-19. So I'll toss that out there, and just whoever wants to go first would love to hear your ideas.
Ladies. I can start, and I'll just kind of throw this out there, but I think the ideal world would be is that we can have the same level of energy, and including financial resources in the recovery as we have in the response. And so thinking, it needs to be at the same scale in terms of thinking about the equitable response equitable recovery. And that's going to require, big investments and big investments in state, local, and communities to address some of these underlying inequities that we're just talking about. Rethinking and recreating systems is a lot of work, and it's going to take time and resources to do so. But I think, I think what I'm, thinking about a lot is like, how do we take this moment? And I hate the term silver lining, but, in some ways we have the stage in a way that we've never had before. I think the pandemic on top of, the social unrest and continued murders of Black and brown people have raised this issue in a way that I haven't felt like we've had this opportunity before. And so I'm interested in how we don't lose that momentum, how in a year from now, when things are finally looking better, we don't start holding budget hearings again and start just going back to the way things were. How do we actually take the step forward and start to address some of those underlying inequities that we're talking about?
Yeah, I can jump in and build on what Meredith said. We really came out in large numbers to protect the democratic space that the movements were able to win. We fought for the right to vote. We ensured that every vote is counted. And I think that there's going to be a very strong pull towards centrism in this time because of the polarization of our state and our country. And even California is becoming more and more polarized, I think. And so I think we need to be really bold and stay bold. I mean, one thing that we learned from the right wing is that they are values driven, they will not back down, and they are bold. And so in many ways, we need to ask for the solutions. When we ask for solutions, we need to go for the strongest and best ones that we know work. We need to pay workers who are sick or exposed to stay home. We need to provide economic security, maintain housing eviction moratoriums, invest in health and divest from the carceral system. And I think part of it is really a narrative, a unifying narrative about what public health is. And this ties into that earlier comment of Sarah's, that public health is its best when it's invisible. And I think those of us who are long game public health people take certain pride in not tooting our own horn and not actually explaining what public health is. But in fact, we need a new vision because one of the fears I have is that we're going to really backslide on the public health that we need to go forward into recovery, that we're going to go back into an old traditional style of public health, when in fact, what we need is an explicit focus on racial justice and public health. We need to continue to tie in a class narrative and a gender narrative and push for a public health infrastructure that is very different than the public health infrastructure that is from before the pandemic. We need a public health infrastructure where every single health department has staff to do health and all policies, climate change, health equity and racial justice, and that it's funded, mandated, enabled through ordinances and legislation. And so I guess we're going to be putting out a policy platform for the Biden administration that is sort of built on the COVID equity policy platform we put out. And I think my big takeaway is really, let's stay steadfast and let's make the narrative push us towards the solutions that we need are also politically feasible, because we have been saying them over and over and over.
Yeah, there's so many things that you've all said that are just fantastic. And I do want to underscore that I think that public health does need a new framework. It's like we need the education and we need the services, but we need to look at systems change. And I think in particular, the power that laws and policies can really play at this time, because that's how things get perpetuated, right? Is when you have those laws and policies that are sort of linked back to segregation and racism and discrimination, that's what you're going to continue to see trickle down. It's just perpetuating the status quo. So we do need to really look at those and examine them and start thinking about how do we make sure that our laws and policies are actually baking in equity from the beginning? How are they really dismantling those systems of oppression and discrimination and racism? I also think, Dr. Chow, you said it great, local solutions. Where can we lift up local solutions? How do we look and really fund people at the local level to be innovative? Those are our laboratories. That's where we're testing things. That's where we know things are working, right? And so I think really listening to people and really funding those local solutions. And I think also, and I'll just echo too, the cross-sectoral and health and all policies approach. We've seen it working, right? We know it's happening. And this is a time in which it's we could just be blowing up the systems in a really good way that are really helping, again, to address some of those structural inequities, like Solange, you talked about the employment and how employment systems and public health systems are working together to protect employees at this time. So let me, yeah, go ahead, Dr. Chow, and then we'll kind of take some of the audience questions as well. So audience, I just want to tee you up. If you have questions, if you can put them in the chat and we'll start filtering through them. Sorry, Dr. Chow.
Thank you. I want to echo all my colleagues, what has been said by all my colleagues. I think that from a community, I started out as a community advocate and activist first before I even went to medical school. And so from a community perspective, I think that I don't mean to be dark about this, but if we don't change the way we view and put together infrastructure for public health, we will have another pandemic in the next decade. That means we have to create an infrastructure that is sustainable for public health. But that sustainability is not just funding to the public side, because there are philanthropists who are looking at the health and the social inequity, and at the local level, there have to be that private-public partnership. This vaccine, there's a lot of philanthropists who are putting money into it to make sure that we speed up the process effectively and appropriately in order to make vaccine available, right? And so we cannot forget that public-private partnership, because the public cannot do it alone. It is impossible to do it alone, right? And then we also need to ensure that public health is not just about communicable disease. I think Floyd mentioned about the climate change. There has been a body of knowledge speak about all of this epidemic and pandemic and all this infectious disease event that has happened this last decade. It's tie into climate change. We got to address that. We got to teach students young on what they do, what we do as a human race to our nature, to the ecosystem that created all of this infectious disease disaster in this last decade. And we need to really train ourselves on how we together can affect that. And lastly, I would say is that working with the local solution, with the local CBO to address the social and health inequity is most important. And a lot of it has to do with the social justice piece, right? And so community solution with the private, with the public, and the process has to be shortened. You heard me talk about it before. The process for government to work with entity outside of government takes months and years to happen. People's lives can't wait for months and years. So we have to change that infrastructure, that systemic issue as well.
+1 to that. I think that's brilliant. I think Solange went off first and then Meredith.
I'm so sorry. What are you asking them?
Oh, sorry. I thought you had a comment. Meredith. Okay, Meredith, did you want to chime in, and then we'll start to take the audience questions?
Yeah. I think one other just piece to highlight, and this is I'm in some ways making a plug for CDPH and for other local governments, but we're also having people retire at enormous rates right now. We have a public health workforce crisis where we cannot hire people fast enough, and people who are, and so I would encourage, for all those on the line today to, to have a good inside outside strategy, we need people from the outside on the inside and inside on the outside. And similar to Clayton, my background, I was a community organizer before coming to the state, and I would encourage folks to consider coming in and helping us from the inside, because we need the champions on the inside pushing, as well as our partners on the outside.
So I want to switch to a question that we received. So it's kind of a two-parter, so I'm going to ask it in sort of two different ways, or I'm going to ask kind of two questions. So one, and this is Meredith, this is going to be directed at you, although Dr. Chow, you're totally welcome to chime in. It's about data collection. So there's a question about, the collection of SOGI data, which is sexual orientation and gender identity. I know that that's been a challenge at the state level. So if you could talk about that. And again, Dr. Chow, if you want to weigh in at the local level. And then Meredith, if you could also talk about how the equity metric, it's focused on the Healthy Places Index. Could you break down a little bit about like why we chose to use the Healthy Places Index as the indicator for the metric, and recognizing that it doesn't consider certain factors, it considers, so I think just talking a little bit about the use of that for the health equity metric would be great.
Yeah, so I'll start with the first part about SOGI data, and just to acknowledge that we've not done a good job, and we know that, and that's not a helpful answer. I also recognize that. So there are a lot of conversations underway to try to better collect SOGI data. Excuse me, not just SOGI data, but also, we have similar issues with our Native American, Indigenous population, our Pacific Islanders, and other, Asian American groups. And this is, even with well-intentioned laws, and this is an area that we continue to struggle. And I think this is, again, something that we've seen. This was a problem before the pandemic. We knew that collection of SOGI data was a huge problem, and also, being able to have, all the other issues in terms of access and culturally competent care for our LGBTQ population. So I don't know that I have a great answer. I'm happy to follow up offline. We in the Office of Health Equity do have now a gender health equity unit. It's a very small, we call them small but mighty unit, and they are working specifically, the part of their initiative is looking at SOGI data and how do we do better, both now, but also in the future as we continue to move forward to collect this type of data. Clayton, I don't know if you had anything else you wanted to add from the local.
I could share with you, before this role, I worked for health plan and health system, and I'll tell you, the social justice knowledge among health provider is not that great. I remember tons of conversation with my colleagues, mental health and physical health side providers, in explaining why SOGI data are important. Many of them was completely, I don't want to use the word ignorant, that's too harsh, obliterated by the issue around social justice. That's where the resistance and why, well, that's extra work for me to collect certain data and extra data entry and what have you. And I think it's fundamentally because healthcare providers, and this is a wider term, are not really aware of the issue around social justice. That's where the resistance comes from. And so we need to do a lot more education, a lot more open conversation among the healthcare providers on why is it that those data are very important when it comes to specific vulnerable community, the disadvantages of the inequity that occur for the community. So.
Yeah. I'll just chime in because I used to be with CPEN, and that was one of the issues. I mean, CPEN is like one of the leaders on data collection and analysis. I do a shout out. And this is a quintessential perfect example of the need for that inside outside strategy. We need advocates to be pushing, right? You have to keep pushing, you have to keep talking about it, you have to keep raising the issues. And know that there are advocates on the internal side of government who are looking at this and who are trying. Data collection across the nation is challenged, right? And again, just another example of like, we've been talking about data collection for 25, 30 years in the advocacy community, right? And just now it's when people are like, oh, we need better data collection, right? You hear people calling across different platforms, folks who had never called for better data collection in the past. So I do think it's like, it's one of those things where we need to keep hammering, we need to keep talking about it. And I think know that like it's challenging because you're also relying on many different entities who've got to get on the same page, whose systems don't always talk to each other. Not everyone agrees on what the categories are, right? So that, I think all of that is happening at the state and local level. And again, I think this is sort of the light in the dark times, which is it's something that people are really honing and focusing on now, knowing that like, hey, we really need to know this information. We need to make sure that this data is collected and work with the communities who also know how can we make sure that we're asking the right questions in the right space, that it's self-reported data, because that's the best kind of data. So I'm going to shift now and just see, Meredith, if you could talk a little bit about the health and equity metric.
Yeah. So just a little bit of background about the Healthy Places Index. I hope most people know about it. What you may not also know is that actually CDPH actually helped and has been involved since the creation of the Healthy Places Index, and actually staff from the Office of Health Equity and some of our data have helped inform that process. And so we've been invested in it for quite a number of years now, and specifically started investing in it because we felt like we needed a tool that we could really look at how a range of social determinants of health, economic, housing, transportation, et cetera, were directly correlated and had linked to life expectancy, life outcome. And so this tool, and part of the reason that we used it in the selection for the health equity metric was because it is, we feel like, one of the best tools out there that has the data is widely available across the state, although recognizing it's not this level of specificity in some of our smaller jurisdictions, which is why the health equity metric, it applies to only our larger jurisdictions as written, so it's over 106,000 residents. But that it provided evidence, well-documented evidence-based kind of social determinants of health and how they relate to health. And so that was selected as a tool, and it doesn't include things like race and ethnicity. And so I acknowledge that there is a layer that you can turn on if you would like to look at some of that data together. Part of the reason that race and ethnicity are not directly included in the HPI is has to do with some various federal and state regulations about not being able to allocate money based on race. And so that was actually intentional that it was left off, so that we could use it as a tool to allocate money without potentially running into issues around those various state and federal guidelines. And I'm actually forgetting the rest. I'm actually forgetting the rest of the question. I apologize.
Yeah, well, I think because the question, I think, was, we've talked about this in other venues where it doesn't, like the Healthy Places Index doesn't account for race, ethnicity, for example. It wouldn't account for sexual orientation or gender identity. It wouldn't account for certain things. And so I think there's a question on the table, which is like, why did we use that metric if it doesn't include these other things?
Yeah, and unfortunately, because of historical segregation, because of inequities, what we are measuring in the Healthy Places Index is highly, highly correlated with race, ethnicity, and SOGI and other vulnerabilities. And so in many ways, it's a good proxy for a lot of those things for race and ethnicity data. But again, some of this is again tied back to our limitations on being able to actually direct funds based on race. So we legally cannot do that. And so that is, how do we actually still try to have an equity and a racial equity focus in terms of our funding allocation without running afoul with legal rules. And Solange, I know you've been really involved in HPI over the years. I don't know if you have any other things you want to add.
I think you said it. I'll just say it in a different way, which is that when the California Alliance and their steering committee tested racial categories against the Healthy Places Index categories, they found that those places with the lowest Healthy Places Index coincided with positivity in COVID testing for each race. And so actually it's a very good proxy, and that is because of exactly what Meredith said, which is because it basically puts racism into its context of its systemic nature, that it's embedded in the housing data that's in there, in the economic security data, in the income data, in the educational data, that each of those systems has racism embedded in them. And so they show up, unfortunately, in the Healthy Places Index in a very accurate way.
Thank you both. I think that's really helpful just to give people a sense of why that in particular. So then there was another question a little bit more about sort of data and other metrics. So there's a question about if CDPH is open to other metrics, and in particular, a metric that I think UCLA has developed, it's PHV, and I'm not actually familiar with that metric, so I'm not sure what that means, but if there's just openness to using other metrics going forward, and if there's a need, I mean, I guess that would be another question, is if you found in your analysis, is this metric working? Are you trying to get at the communities that are the sort of the targets of this equity metric?
Yeah, so I'm actually also not familiar with PHV. What I will say is, prior to the pandemic, and still for our other programs, we do use a range of tools in thinking about how we identify and target resources and programs, including how much money we provide to local health jurisdictions. So I think that's always an option in terms of thinking about all of our programs moving forward. I think and I think we haven't adopted any official tool. We are using HPI right now for the COVID health equities metric, and we will almost certainly be, I don't think it's an official, but it's looking like we'll probably use it for our vaccine metric as well. So I don't think there's going to be any, and again, I can't fully speak to this as decisions made above my head, but I don't anticipate there being a change of the metric base. So I think HPI will be the metric that's used moving forward throughout COVID response. And I think that there are opportunities moving forward in all the work that we do to think about what tools are out there. And if there's a better tool, I think we're definitely open to hearing about it and want to work with partners to continue to elevate it. And I see that Clayton has a comment.
Hi, Sarah. So in Orange County, before I came on board, I didn't realize that we were not part of the Public Health Alliance of Southern California. Immediately we joined, and we learned about the PHI. However, we have brought in to Orange County a tool called Social Progress Imperative, known as SPI. And this platform is standardized internationally. And California at one point did look into SPI. I don't know what happened subsequently, but nevertheless, we overlay the census data on top of it and COVID data on top of it. And so we are able to identify an area in our county that have the most impacted in terms of the 52 elements on social and health performances. And we also match up with the ethnic concentration in each of the city or zip code, and we're able to pull up which zip code, which neighborhood has the highest infectious rate, and which ethnic group are most affected. We look at our death rate as well from COVID, and we're able to identify them. When we compare HPI and SPI, pretty much the lowest quartile information and pretty much very similar, except for SPI afford us a much more information in area that is unincorporated, because remember HPI is based on state and federal data, so there's a lack of collection for unincorporated area in each county, and so we're able to use that in a bit more laser focus into our different neighborhoods in Orange County.
I just want to add one more thing, which is that I think HPI, as has been said by both of my colleagues, is an amazing health equity index, but it doesn't include certain things that are very specific to COVID vulnerability. So essential workers, incarceration. And so I think that similar to using it for climate change, like you really need to think of it as social vulnerability, and then like look specifically at the things that at a local level are making people more vulnerable. So for example, Los Angeles County Health Department is making their COVID infection data available at the work site level, so that you can actually see like that Target store has had high COVID infection rates, instead of just like the number of workers in retail who have COVID in the county. So there's other ways that counties are looking at displaying the data that gives residents more ability to kind of control their own risk, but also gives local health officials more ability to really hone in on the hotspots.
So if I may, I'm going to use that example because in Southern California, each of the county have been displaying our information very differently. So that speaks to the inconsistency. But as related to COVID, I have a different feeling in showing specific, that stigma is still very high. I mean, the fact that we talk about high positivity rate in certain area, unfortunately, it has created this stigmatized and discriminative feeling among people. And I have to keep telling people, yes, that area light up because the test result only show where you live. It doesn't mean that the area with the lowest positivity rate is a safe place for you to go, because people don't work there, right? Unfortunately, it's everywhere in the community. And I know it has prompted a lot of conversation. I know I got beaten up by the media. How come you don't do this just like LA and name businesses? And I said, but what's the point in naming different businesses? Everybody should be doing everything you can to protect your neighbor, protect your family. And so I get weirded out when we talk about how we display information and how we need to be mindful and not unintentionally stigmatize a neighborhood or a city or an area, so, or a business for that matter.
Yeah, and I think that actually hits on like one of the big challenges that we're facing throughout this pandemic, and I will also acknowledge HPI is not a perfect tool. There is no perfect tool, and one of the things that we're even talking about right now is the challenge between a place-based approach versus a population-based approach, or data or indicators, and it's something that right now is a big topic of conversation with the vaccine allocation. How do we allocate vaccines equitably when we have both incomplete data or inconsistent data? In some cases, we have some information that's place-based, but we also know that, I think just what Clayton was saying is, we know where the farm, we know where communities go to do their work. And so I think this is just, I don't have a good answer to any, or a good solution, but just to acknowledge that it's a both and approach that we need to be thinking about, and to acknowledge that no tool is perfect, and that at this point I think welcome and open to additional thoughts and thinking about how we can improve some of these metrics and tools, and also there's a point at which I think we have to accept what we have and then try to how do we use what we have that doesn't do better, if that makes any sense.
Yeah, and we're going to wrap up. So I'm just going to ask the panelists if you want to kind of get your 1 minute closing remarks ready. But I think part of this is like, I think people want to see themselves reflected in the response, and also in the recovery strategy, right? And so the data isn't going to cover everybody, and we know that there are limitations, but I think to really understand those particularly vulnerable, and the smaller populations, right, or the populations, Dr. Chaz, you're talking about, that are stigmatized, that don't want to come forward. So, how do we really center those? I think we've approached this pandemic in many ways from our own privileged position, right? We all work from home. We have computer access. That is not the case for the immigrant working mother who, is struggling with, childcare and language issues, right? So to really center kind of the most vulnerable and to have people see themselves, I think, in the response and recovery and called out in some ways. This is how we're going to address these various different types of vulnerabilities, if you will. So I think that's really important as we go forward. So we started with Meredith first. I want to shift to maybe Solange first. So if we can have you go, and then Clayton will stick you in the middle again. And then Meredith, if you want to close us out, that would be great.
Yeah,
So
I mean,
yeah.
I think I'll just say, I'll just kind of repeat what I've been saying in various ways, which is that we really need to continue our work to support social movements with public health. We know that social movements work. We know that social movements are actually speaking for and with communities that are experiencing the worst inequities and that actually know they are the subject matter experts of what is going on the ground. And so what I'm most interested in right now is really fine-tuning our inside-outside strategy in such a polarized time to help create institutional change, policy change, and really understanding the exact steps and the time frame and the approach to help both government and social justice movements and organizers move our agenda forward together. So thank you.
So we need three things. The first thing is we have to acknowledge that solution is local. We know, the community know where the needs is, right? Second thing we need is we need a sustainable public health system that are public and private partnership. The government can't do it alone. We are delusional if we think that we can do it alone. And thirdly, I'm not a politician, I'm a doc, but it's clearly this last year, what we need is kind and caring leaders. That's it. No politic involved. Doesn't matter what political side you're in, we need kind and caring leaders, period. Because only kind and caring leader can address the social injustice in our community, in our society. That's it.
Awesome. Meredith?
I don't know how you followed that, but I will say I think the thing that's sticking with me right now is the need for not only an equity-based response, but just a real human-based response. And I think this is going to the human kindness and human caring that that Clayton was just talking about. But how are we designing our response, our systems, our recovery in a way that really centers, starting with our most vulnerable, starting with our immigrant mom who doesn't have broadband access? Like, how, if we were to take her and center her in all of our solutions, we'd be designing better solutions for everyone, and doing it probably in a much more caring and thoughtful manner too. And I think the last thing I'll say is, I just am really eternally grateful for this forum, for the partnership that the folks on the call have provided, and also just encourage you to reach out. I think it's a hard time to be in public health. It's taken as Clayton mentioned, a huge personal toll, and people everybody's tired, and I think when you can offer some of that appreciation and love back towards the public health department as part of a relationship building, I think it would be appreciated for them.
Agreed, Meredith. I think those are great. I just want to say +1 to all of the panelists' comments. I think those are really super important. I'll just add, I think having that health and all policies kind of interdisciplinary approach, breaking down those silos right now, and really thinking about those, dismantling the legal and policies that have been there for so long and that are just continuing to push the status quo, and really building back differently in a way that's centering equity and eliminating those inequities. I also want to thank CPEN for having us and for having this conversation. It's so important at this point in time. Thanks to all the listeners for being here. And thanks, of course, to my phenomenal panelists and colleagues. You guys are amazing. Much love. Thank you, everyone.
Thank you.
So great talking.
Thanks, Al.
Bye.